I've always said, from my own personal experience, when I try to talk to people about the need for these spaces, is it's really a thing we do more than a place, but it's of course both. And they can be done. You can give access to people to use drugs safely in all sorts of different places, whether it's a room in a hotel, in a housing project, or a couple of kiosks in the emergency department, or embedded in a community health clinic. And the sort of insight experience that we went through in Vancouver was very much about just trying to push through a place, a physical location where we could exist beyond the drug laws and say here within these walls, which was what we used to find exceptional when we opened, was the laws that apply to everybody else in the country around active drug use don't apply here. It's like this little decriminalized 1,300 square feet, which was in and of itself at the time a pretty emotional and dramatic feeling to be able to walk into that space. And I always say, it didn't feel so much like a public health intervention. It is almost like going into a church. You know, like the first day when it opened and people were coming in off the street after so many years of no other alternatives to seeing people using in alleys in the dark and just the dirty puddle water or whatever the conditions were that people were using in. And then the dignity that they felt when they walked into this very nicely well-lit space with nice music playing and staff that were just friendly and talking to them and saying, how are you doing? And without any judgment. Not only was it really transformative for those of us watching and feeling like this dignity had entered people's lives that just had never experienced in that way, but also the users themselves, you know, right away would remark on, oh, I can't believe you guys are being so nice to me. Or like, why are you treating me nicely? Like nobody else treats me nice. Like, which is such a horrible reality, but it was true. And all of a sudden, we went from being, you know, a place where people had never expected that to where they came to not only expect it, but advocate and fight for it everywhere. And that was really powerful and transformative in and of itself as a movement. So I'm really delighted that this work is being carried out all over the world. Our panelists today are Swathi Srinivasan from Boston in the US, Gurvan Bourhis from Paris, Marcus Hammond from Edmonton in Canada, and Christian Niemann from Cali, Colombia, all presenting on different aspects of drug consumption rooms. Each speaker will have about 12 minutes to present, and then we'll save our questions, if you don't mind, until everybody's finished presenting. Our first speaker this morning is Swathi Srinivasan. Swathi is an AmeriCorps Fellow in Overdose Prevention at the Boston Healthcare for the Homeless program. She was a Rhodes Scholar and documented community harm reduction overdose response in 20 countries. When she was at Harvard, Swathi co-founded the Harvard College Overdose Prevention and Education Studies, helping to implement legislation on public access to naloxone. Swathi is going to be presenting her research on the sociology of space, juxtaposing overdose prevention centers around the globe. Let's welcome Swathi.
Hello. If it's okay with everyone, I'll be presenting sitting down because when I stand, I start to fidget a lot. I'm very nervous and excited, and when I'm nervous, I speak quickly. When I'm excited, I speak quickly. So I'm gonna do my best here. Thank you for the introduction. I'm really thrilled to be presenting. Oh, thanks. Oh, yeah, helpful. On the sociology of space. So sociology is the scientific study of human societies, particularly organization and change within structures, institutions, and frameworks. In this presentation, I'll be looking at physical structures and attempt to showcase how differences in these physical structures can reflect the different priorities of funders, communities, politics, and beyond, especially in the places these spaces operate, but also the differing forces that might be in play from city to city or community to community. Part of why I studied these spaces that are already pretty cool, like OPCs, is because I'm not particularly just focused on survival, but also on thriving. I believe in the highest standard of care for folks and of love, and I believe in sharing the knowledge between communities and cultures can help get us there. Before I begin, just a few acknowledgements that we are on the ancestral land of the Muisca and Chibcha people. This project also features research from the Musqueam, Squamish, and Tsleil-Waututh nations, as well as the traditional lands of the Sami people. I am indebted to these communities and to these folks who have stewarded these lands over time and always will. I also want to acknowledge the racially, ethnically, gender diverse, immigrant diverse, queer communities, differently able communities, and the people who use drugs in this room and beyond who have built the systems of strength and resistance that I will talk about today and beyond. But I do want to flag that this work is difficult, it is personal, and I'm thankful to you all. So, the question of space. Before I get into that, I kind of just want to give a little bit of context. This was part of a much larger project where I was documenting overdose response efforts around the globe. But I became increasingly interested in space as I went from place to place. How did these community harm reduction spaces reflect culture, reflect societies, reflect people who use in their communities, reflect funders, reflect politics, because they're not often the same and they don't always intersect the way we want them to. And to do this, I did photography, I did interviews of over 100 folks around these communities, I joined site visits, outreach, shadowed, and my background is also in harm reduction for the last 8 years, so I came at this project with a little bit of knowledge on these spaces in my own community, but wanted to see this elsewhere. We have a lot to learn from each other, as this conference has shown us. So the literature on spatial analysis in anthropology is actually more new than you'd think, coming from around the 90s, and spaces can be seen a ton of different ways. This is a non-exhaustive list of the way that we look at space, from where these kind of spaces are positioned. Are they in urban environments, suburban environments, rural environments? Are they distinct or are they unassuming? Do they stand alone or are they integrated? Are they spaces of surveillance that we're documenting who's coming in, who's leaving, or are they anonymous? Are they clinical, non-clinical? Are they political? Are they apolitical? And that's just, from the outside coming in, looking inside these spaces. Do they have indoor and outdoor space? Are they communal or do they sponsor for individuals? Are there staff-only spaces, which is something that is highly politicized, or are they all shared spaces? Are they full of color and art and light? Are they grayscale? Are they artistic, eclectic, or are they uniform? Are they quiet spaces or are they loud communal spaces? There's quite a long list there, but there's a lot of literature on it that I'll show you at the end if you're interested. I'm going to start just with the facade, and I'm going to use an example in Zurich and an example in Geneva. Already you can see sort of differences in how these two OPCs present. One is part of a kind of long-standing facade. It sits across from a North Face store. You wouldn't know it unless you knew it and were reading the signs as you were walking. That's in Zurich, and that is a city-run overdose prevention center. On the right-hand side, you see a neon green shipping container-esque OPC that sits near one of the largest train stations in Geneva, actually the largest, Gare Carnevin, and it is run by a nonprofit that received government funding. And both of their approaches to creating these OPCs and where they were positioning them had to do with the idea of wanting to make them part of this bigger effort to include people. Now, one is unassuming, business as usual. We want folks to feel normalized in culture, that you're just walking across this street in this commercial area, an OPC can exist in a shopping district. The other is saying we want to approach this and see this, notice it, give it light, give it kind of our attention. And so both have that similar goal of sort of integrating folks into the community, making sure that we're seeing people as they are. But at the same time, they take two very different approaches to that. It's unsurprising that on the inside of OPCs, it's also quite different. We see smoking as commonly a communal activity, but some smoking areas in OPCs, which is a relatively newer phenomenon in OPCs en masse than at the start, which were largely injection facilities, as folks know, some see smoking as communal activity. Folks can come in groups, interact with each other. That on the left-hand side is Oslo in Prince and Mottach Center, but on the right-hand side, you see in Copenhagen, in Men's Home, these sort of individual booths that seat only up to 2 people. These are choices made by the OPCs. I've asked about these choices. I'm happy to tell you more about why those choices were made. But it tells you something about how substance use is seen as either an individual or a communal activity and whether these are permitted by the folks that run these OPCs. So there's quite a lot there, and you can see that there's not also a discrete answer. There's also semi-individual and semi-communal spaces where folks can be, interact with each other, but there are sort of dividers between different tables, different seating arrangements, things like that. And now I'm really interested in this because it's, one of the commonalities here is like the capacity control for these spaces. A lot of them are funded by departments of public health, in which case they have to adhere to very many codes and then have to follow all of these rules. So at the end of the day, there's an aspect of kind of data surveillance too. which is something that I'll get into later. Okay, so what we've seen so far are pretty clinical examples. And on the left-hand side, we got insight, which is, as we talked about, a kind of prime example here. You can see in the reflection in the mirror kind of what that semicircle booth looks like. So folks can be seen kind of entered in. They are kind of monitored kind of booth to booth. That could not be more different to Manzanares in Barcelona, where the kind of substance use space is a very small aspect indoors of a much larger artistic space. It's not one that is highly surveyed. It's kind of these two rolling chairs that sit on this table. Folks kind of clean up after themselves. They wipe down the tables. There's like a, spray bottle on the side, a sharps container. But it's very unlike the, I think, 12 booths that you kind of see inside. You see kind of number 12 there, but it kind of sweeps across the room. And I found this really interesting because, for how harm reduction spaces kind of were created, which were very non-clinical, non-institution, some of how they've been given legitimacy is through, their kind of government reaction. But people know who have been in these movements that is not where they gain their legitimacy. They gain their legitimacy from the knowledge of peer communities, people who use, people who know this space better. And so what I find really interesting is that these clinical spaces were also more likely to register folks to take down information. Sometimes you can give an anonymous code, but usually you have to show proof of concept to a funder and show like the return on the investment, which is very much not why we do this work. We do this work to support the folks that we want to support, which is everyone. And so there are these different registration means, and that on its own is a form of surveillance. And you're more likely to have to do something like that if you're reporting to a Department of Health or operating under the auspices of a Department of Health. Manzanares, on the other hand, while it receives support from Catalonia, is kind of run by a cooperative. So the way that it operates has been very much built by the community of people that it serves, and it looks very different for that reason. There are also kind of artistic aspects of these spaces, and being more or less clinical does not preclude you as an OPC from having art and color. But in fact, research suggests that the presence of this art, the presence of this color, especially from people who are in this community providing that art, increases buy-in into the space and comfort in that space. That's not really a surprising thing, but it looks very different. So you can see kind of on the top left there, the inside of Kinouf in Geneva is the same color as it is on the outside, whereas kind of Zurich, you kind of got those white walls, the occasional splash of color. You've got art made by people who use, and the siblings of people who use up there in Oslo, and in Lisboa, you have folks that are using the OPC, creating art while they're waiting to use the space, which is what you see down there. In Barcelona and in Manzanares, I thought one of the coolest things is as soon as you enter, the strategies of kind of self-support, self-care were made by people who use and put there and designed as the community, which I think is just one of the most beautiful ways you can have folks be invited into a space and see that their voices matter and are heard, not just in the aspect of using, but also in the construction of space, which is so unfrequent in how we see our spaces created, especially the ones that are more formalized and receive kind of government funding or formal funding. Okay. So it's not just about indoor space, it's also about outdoor space. The idea when we talk about space, especially in the form of harm reduction, we're constantly thinking about surveillance and policing, how public spaces are not safe spaces for our folks. So I think one of the coolest things that I've been able to see is that in OPCs, they created leisure space too, places people can just be, There are very few places people can just be unbothered. So I think one of the coolest parts about kind of doing this project was seeing, like, in Insight, you've got sort of an indoor seating area with the TV. Barcelona has an outdoor, it's a smoking area, but also just like a hangout area. In Copenhagen, in Men's Home, they've got this outdoor cafe area, which is in a former meatpacking district, and people can use outdoors, they can get coffee, they can talk to social workers, and it's all in this sort of like, walled meatpacking area that's right next to a pretty kind of bustling bus area and train station, and it's sort of inside, behind here. And then in Oslo, they've got, connected to Prinsen Matic Center, an outdoor kind of hangout area where folks can get fresh oatmeal and smoothies in the morning. And that's kind of led by the staff, but also by folks that use, that can participate and kind of converse and also lead that space. The walls are painted by folks who use the space. And it offers an outdoor kind of area, even in a place that's pretty cold like Oslo in the winter. So this is the very beginning of a much larger project where kind of OPCs will be surveyed across the world. And that's like kind of in collaboration with some folks at Brown. But some key takeaways here is space none of this is, I think, surprising to anyone, but I think it's cool to see in this context that space is a reflection of culture, of politics, of your funding priorities, and so much more. There's also a lot of nuance there, that even though there's the similar stated goal of protecting our folks, these approaches are vastly different, and that's highly dependent on who's supporting these efforts and who's leading these efforts. One of the most interesting things to me was seeing a harm reduction as an approach, a thing that is sometimes tacked on or seen as a separate, versus as an integrated ideology and philosophy. I think Metzinedes is a great example of like harm reduction being part of something bigger, of supporting women and non-binary folks, not necessarily seeing the consumption room as its own thing that is the focus of this space, but as something that is part of a much bigger picture of our own humanity. That said, you can also see that clinical spaces were not necessarily distasteful, and they don't have to be ugly and highly medicalized. They can have art, they can have light, they can have color, they can be human. And quote, non-clinical spaces are not necessarily unscientific or non-medical in their own kind of support of people's health and wellness. Sometimes you need all of it, right? So instead of seeing kind of harm reduction as a distinct practice, seeing it as part of something bigger, part of that shared humanity, I think is really cool. So yeah, consumption spaces, especially in OPCs, can reflect mode of use, but that's not always the focus. I think that's pretty cool too, that we often think about OPCs in their own place, their own topic, but they can be part of something bigger. They can be part of housing, they can be part of cultural spaces, they can become part of social spaces, and perhaps we'll actually reach more people when we do that, when we see a person not just defined by their use, but by other aspects of identity, which link us to. And I think art is a great way to show that participation and to show that input. Okay. Here is some fun reading on anthropology and sociology for folks that are interested. But I just want to say a big thank you to every organization that has hosted me, every person that has listened, and all the folks that have worked on this project, which is now a much bigger team of people in different parts of the world doing interviews in their own community. And these are folks that use, folks that are interested in harm reduction but have not had experience, and every range in between. Thank you.
Awesome. Well done. Thank you, Swathi. That's cool. And it's really interesting for me to think about how these spaces can evolve and change as the sort of political and funding restrictions hopefully loosen in some of these spaces where they've been for a while. Because as we all know, we have to jump through hoops to get them open, and then ideally some of those more restrictive aspects of what we are and aren't allowed to do change, and I love it. So our next panelists are Gurvan Lebois and Naira Miliava, who are here from Paris, and they're going to introduce themselves, but they're going to be speaking about a really cool project they've been working on called ESAR, which is supervision and support spaces for harm reduction. It's an innovative and creative way to for drug users who are organizing and working on introducing a common set of principles and practices to provide services in unsanctioned spaces. So given that there's only 2 drug consumption rooms in France for 67 million people, they've been looking at creative ways to kind of get supervised services in unsanctioned spots. And I think it's super cool. So thank you so much for being here.
Hello. Thank you. My name is Gurvan Bourhis, and I won't speak as fast as my colleague, so I will take some time, and excuse my French accent. So I've been working with drug users for about 15 years, mostly in Paris. During 3 years, I was in the first DCR in France. I worked as a nurse, and now I live in the city of Nantes, and I work in a harm reduction center.
Hi, happy to be there. I'm Naira Miliava. I'm a psychologist, and I'm the executive director of Opelia, one of the organizations who tries the ESAR project.
Okay, so we are going to explain the project called ESAR. In French, it's Espace de supervision et d'accompagnement à la réduction des risques. And first of all, we are going to explain you the French context on harm reduction. So some few key dates to start with. Just to tell you that all the people that come to our centers can be anonymous, and all the services are free of charge. So a brief history, we had a very high HIV epidemic among drug users in the 80s and 90s, but it's only in 1987 that we had the first needle and syringe program run by a non-governmental organization. The first OST with methadone and buprenorphine arrived in 1995, which is quite late for a European country. But we had really a very good access to buprenorphine thanks to the prescription of general practitioners. There was a very important law in France in 2004 for harm reduction. And we have now a lot of harm reduction centers funded by the government since then. And as we said, it's only in 2016 that we had the first DCR, and now there are only 2 running at the moment. So it's only an experimentation. First of all, it was 5 years, added to 3 more years, and now we are at 8 years of an experimentation. So 2016, you can see that it's the end of the experimentation, and we are very scared that they may close at the end of this year. So to summarize, as I said, we have a health system quite open in France, free of charge. We still have a low distribution of needle and syringe if we want to reach the WHO targets. But we have a quite high coverage of OST with a large number of specialized centers, addiction centers called XAPA. There are around 500 in the country. And the CARUD, who are harm reduction centers that are 150 centers in France. To talk about the substances used last year, for example, illicit opioids were up to 0.3%, but cocaine with a large increase those past years, and last year was 2.7% of the general population. So the 2 DCR opened in 2016, one in Paris and one in Strasbourg on the east of France, and none since. Even though we have a very good and positive impact, acceptability, and a proven effectiveness, thanks to research laboratory, but we really have a lack of political support. That's why there are no major cities that have DCR since. For example, I can tell you 3 cities like Lyon in the center, Marseille in the south, and Lille in the north, which are cities that have more than 1 million of inhabitants. All the projects are blocked. And as you said, Liz, in France, we have 2 DCR for 68 million people. Compared to Switzerland or Netherlands, we are very low.
So that's why in 2023, we speak about French Addiction Network, Fédération Addiction, and the idea was simple. We need to find a new approach. If consumption rooms are blocked, we want to continue to fight for them, but we have to need something and to do something for our center. That's why we tried to experiment a new space, supervised space, directly in our center, in harm reduction center. This 1-year pilot project comes with research support to provide evidence. So now we are speaking about Opelia. Our organization is one of the organizations in addiction care in France. We have 54 facilities, 60 professional workers. Our values are clear: inclusion, human dignity, innovation, and non-judgment support. We joined the ESAR project to offer supervised space for people who use drugs and to push forward a pragmatic, respectful of harm reduction.
So that was in 2023. Let's make you a little picture of what's happening in our centers. We knew there were drug use inside our center in unfit conditions, like the toilets, for example. Even in some centers, we had dedicated places, but the safety is not really ensured. Of course, we have drug use in public spaces, parks, train station, as well as homeless shelters, parking lots, squats. We offer intervention, providing training and education about injection. And we have a consensus of field workers to develop supervised sites inside our centers. We also have an acceptability of drug users to come to our centers and to be supervised. So the goals of that ESAR project are similar to a DCR. We hope to ensure harm reduction to people who use drugs. We reduce negative support and negative impact on the society. We wish to reduce morbidity and mortality due to overdose. And we wish to diversify aid approach. And we wish to ensure dignity and inclusiveness of people who use drugs. Also, we secure the professional and preserve safe conditions.
So the project is coordinated by a team, including legal experts and health professional and project manager. It is based on a clear step method, legal analysis, field diagnosis, involving both professional and users, and creation a national framework. Actually, in Opelia, 7 centers are pilot centers in France. You can see all over the France.
So as you said, we looked at the law in 2016 that allowed the 2 DCR to be opened. And we saw that the much broader definition of harm reduction policy. I will read what's written in that law. Promoting and supervising behaviors, action and procedures for risk prevention. Supervise consists of warning users about risky practices, supporting them and providing advice on substance use to prevent and or reduce the risk of infection transmission or other health complication. It does not involve any active participation in the act of consumption. So as you can see, if we want to supervise, we need to accept the consume inside our centers. If we want after the talk, maybe we can go through that law.
So as you can see in these photos, it's very important to understand that we need to integrate space for supervising in our center. Most of them in space who are normally for other services, like on the right side over there, you can see it's just a place normally for giving some materials, and now it's for supervising the procedure. And sometimes in some centers we can install cabin for smoking, for example, on the high.
So our project, after 6 months of working, we had 1,333 supervised acts, so there are consumptions, for 240 different persons. As you can see, the consumptions are mainly smoking, cocaine, crack cocaine, but also some people smoke heroin. And we did some supervision on injection for 326 acts. We can really say that that project saved lives. We had one event with an overdose, which was thankfully reserved with the naloxone inside the center. we were able to test that drug, which was supposed to be heroin. Heroin in France is usually, let's say, 16% of heroin inside the product. And that time we had a product with 76% of heroin and 11% of nitazen. Nitazen is very, very rare in Europe and in France.
But it seems to be important to say that ESAR sites are more than a safe place. The dynamic is very important because people who use drugs can say that it's more than that. They feel welcome, they feel safe, and they can speak more about their using. And globally, we can see that they request more for drug testing and more for different services increased by this kind of services.
Thank you very much.
Thank you.
Fantastic, thank you. That's super interesting. And I love what you said about it's so much more than just having a place to inject, right? Like it's really about that conversation that can happen, that can never happen if we don't actually be there for the act of using. It's so intimate but powerful how it changes the whole relationship with people, I find. Great. Well, our third presenter is Marcus Hammond from Edmonton, Alberta. He has had a broad range of experience in public, private, and community-based nonprofit and non-government organizations throughout rural and urban international contexts. Marcus is an applied public health researcher, registered psychiatric nurse, and a Master's of Science student at the University of Alberta's School of Public Health. He is presenting his research on intersectional risk environments and the role of place, and an urban Canadian ethnographic study of people who use drugs in a central business district. So welcome, Marcus.
Good afternoon, everyone. It's an honor to be here to present in front of you. The time is 3 o'clock, so I'm thinking if we all stood up for a quick second and shake it out a little bit, that will wake us up before the rest of the day. Yes, express it. Excellent. Thank you so much for participating. So this panel has been extremely interesting for me. The study of space and place is very close to my heart. So the discussion today is on intersectional risk environments and the role of place, investigating people who use drugs in a central business district in a Canadian city. So I'd like to just do a quick land acknowledgement. I come from Treaty 6 territory, Beaver Hills House, Musquatchie, Waskahigan, which is the original name for Edmonton. It's a common territory for many peoples, including the Cree, Sioux, Stoney, Dene, Métis, Blackfoot, and many more. Important to acknowledge that as we're considering space and place today. So, folks, the drug-related public health crisis in Canada. In Canada, drug poisoning events are commonly straining health systems. Since 2016, more than 40,000 people have died from drug poisonings in Canada. In 2024, approximately 21 deaths per day. So it's quite significant, and the majority of these drug poisoning deaths involve fentanyl. Ontario and the Western provinces, you can see here, these are the Western provinces. The yellow star is Edmonton, where the study was conducted. These have been especially hard hit by the drug poisoning crisis. The bottom line here is that contaminated drug supply is the leading cause of drug poisoning deaths in Canada. In Edmonton, the population is currently 1.4 million. It's the 5th largest city in Canada, with main forms of public transit as buses, LRT, which is the metro, and passenger vehicle. As well, Edmonton is home to the 2nd largest urban Indigenous population in Canada, so Indigenous-led approaches are needed. It was especially relevant this morning during one of the panels that I attended as well. So spatialization of drug use in public settings. What exactly is this? In 2024, Alberta reported that 31% of deaths occurred in public settings, whereas Edmonton reported 35%. This is in contrast. We know that many deaths are happening behind closed doors across Canada, across globally as well. But there's a significant number of deaths that are happening in public and semi-public spaces. What are the concerns of this? Drug use in public spaces increases the risk of fatal overdose in certain neighborhoods more than others. Non-fatal overdose, elevated blood-borne viral risks, skin and tissue infections, arrest by law enforcement, and other such challenges. So we can say again for the bottom line that environment shapes drug poisoning outcomes. The image left here is a photograph I took while I was doing some research in Cape Town. The image presents the sharing of dacha, which is down, otherwise known as, and so just for context and thinking about how the space informs drug poisoning outcomes. So why central business districts and why public drug use? Again, increase in public and semi-public drug use often occurs throughout central business districts, otherwise known as CBDs, or urban downtowns. What is known about drug use in central business districts? Well, there's limited health surveillance data. There's challenges accessing services and supports. Increased role of informal strategies and supports as well. So we're thinking about the social networking and kind of moral economies. As well, there's limited municipal harm reduction policy frameworks that exist. And finally, there's not a great deal of understanding on how central business district environments impact people who use drugs. So that is where the knowledge gap that we explored. We wanted to understand the experiences of people who use drugs in central business districts to get a better sense of what factors impact their daily lives and make it harder or easier to access services. The central business district and public drug use. So the broad sort of overarching question that we were exploring was how do urban CBDs impact the daily lives of people who use drugs? The particular objective that we want to explore today is investigating how CBDs shape daily experiences for people who use drugs. In particular, wanting to understand what are some of these key risk factors that are known to be associated with this. So how we conducted this study, we used focused ethnography, spending more than 170 hours in field to connect with and interview more than 25 different people who use drugs throughout the area. We used ethnographic observations and field notes, including photography to help contextualize. We then used latent content analysis and an intersectional risk environment theoretical framework to try to understand how different dimensions of the CBD environment shape these types of outcomes. And importantly, we also drew on the lived and living experience of a knowledge user group to help inform those ideas and themes that we were exploring as we continued with our analysis. So participant characteristics, predominantly between the ages of 30 and 44, predominantly First Nations as well, and almost equal between male and female. And then as well, the number of people actively using substances at the time of the study was 22. So not everybody was actively using. In addition, the majority of the participants were identifying as houseless. And so that was important in understanding intersectionality for us. As well, majority of participants had spent between 1 and 4 years in the study setting. So the key overarching themes explore the risk environment and duality of place, an enabling environment and duality of place, and then intersecting marginalities. What this really means in a roundabout way is that the themes were in tension. It was not clear that there was one sort of unilateral theme. What we did find was that people expressed how the environment was both could be at times hostile for them, but at other times was also supportive. And so it depended on exactly, what aspect of the environment we were discussing. As well, part of the intersectional challenges was that we spoke about gender-based violence, housing precarity, and ethnic disparities, and how that tends to reinforce marginalization for people who use drugs and CBDs. Okay, so onto the risk environments and duality of place. In terms of hostile environments, we're thinking about exposure to violence, exposure to inclement weather conditions, scarcity, including resource scarcity, and increased surveillance as well. One quote here, the environment, like the places, like how before you had benches, people would sit down where you can sit down. You can't find them anywhere now. No tents and tarps around here at all. Okay, where else is everybody supposed to go, right? This is where people are supposed to go to feel safe and have shelter, but we can't be around here. As well, reinforced displacement. The image here is of a fence that had been placed after a former encampment was displaced by law enforcement, and speaks to the challenges as well of reinforced displacement. The quote to the side of it speaks to seclusion and secluded drug use. There's a lot of them, isolated, out of the way, hidden spaces everywhere in this area. I can find basically most of them everywhere. It's just that when you're isolating yourself, you're distancing yourself from everyone. I try not to do that, but sometimes I have to distance myself from people because I can't stand people. In terms of enabling environments and the duality of place, again, this is where this tension is coming into play. And so it speaks to ties to place. And when we think about place and space, space is sort of the dimensionality of a given area, whereas place is the meaning that is associated with that type of space. And so to use this quote, to speak to this quote, and so being back here reminds me, like I have siblings that have passed away in different places downtown here. So I go and sit where they died and talk to them, and I feel like they can hear me, and it puts me at ease. So it's a connection, deep and meaningful connection to place. As well as the notion of adapting to challenges. The quote here, I don't think that there is any safe way of using, but honestly, like the whole safe injection idea, I think that was a really good idea. But I think that a lot of community members are too scared to go into these safe injection sites because they're too scared to get, the cops are going to know that I go in there. And so the surveillance, the tension of being both an enabling environment and a risk environment makes it difficult for people to know how to navigate that kind of space. Finally, the intersectional marginalities, again, speaking to gender inequities, the challenges that people would face in terms of emotional and mental distress, exhaustion, exploitation, and the normalization of violence. Quote here, he stood up in front of me and you can tell he was trying to be all aggressive with me, but he was overdosing at the same time. I wasn't giving him nothing else, so I just sat there and watched him overdose. As well, housing inequities and the challenges associated with exposure to weather, exposure to also stigma and discrimination, and the sense of creating home. And so this quote here, usually whatever place I'm calling home, whether it's the apartment I had or someone's tent, or you see a lot of people with blankets over their heads, they're using drugs under those blankets. And finally, ethnic inequities and racialized violence, the notion of surveillance, stigma, and intergenerational trauma was captured well in this quote. When I'm buying alcohol, I risk because I don't like it when the cops stop me and try to take my booze away from me without a receipt. They've done that to me numerous times. To me, it's just like the cops want to pick on me because when they know that I'm walking out of a liquor store, they just pull me over. Do you have a receipt for that? And so the challenge is then in thinking about what enabling environments may look like, we want to be thinking about both the tangible nature, as we can see here in the center with an accessible drinkable water. As well, we're thinking about security in terms of the physical infrastructure, adequate lighting, lavatories and washrooms, as well as shelters. But the challenge is that we have to be thinking about how the policies that are in place are actually informing and shaping not only the physical, but also the social and the economic infrastructure that's at play in downtown business districts. And so we have to be thinking about how to reframe these public policies to include measures to support healthy environments, to support the health of the populations that live there. So some final recommendations. We want to be thinking about comprehensive public policy frameworks that aim to address drug-related harms and foster community belongingness. Again, this is part of that tension of the ties to place and a sense of belongingness to the space that people are in. We want to be thinking about programs that are integrated and offer wraparound services and supports across sectors, including social, legal, health, etc. And finally, we want to be thinking about practice recommendations that include harm reduction education for not only allied healthcare professionals, but also social work, occupational therapy, physicians, nurses, etc. And that is it. Thank you.
Well done. Thank you very much, Marcus. That's great. And super fascinating to me, come on up, to conceptualize space in that way. You know, when I left the PHS in 2014, I had a fellowship with OSF for a year, and part of the question that I was trying to answer was, what had I learned in 24 years of working in this work? And my summary was that all this work is about space in some realm or other, whether it's human space and how do we shift the way people are treated individually with the people that are doing the work, whether it's the policy space or what are the policies that we can reshape to kind of reorient space to make it more accessible and humane, you know, political space that we're always within, and then obviously the physical space and the program space. But I love this whole theme. It's so incredibly important. So anyway, I'm going to now introduce Christian Niemann, who is an industrial designer with a master's in architecture. He focuses on social innovation and in understanding how human and material sources can be found in local contexts, motivating more sustainable design interventions. And Christian is here to present on a project that he's worked with his colleagues that are also here, Danielle Nadal and Maria Luc, who are both part of this same project looking at design specifically in relation to the supervised consumption site here in Colombia, in Cali. So he's going to give us an update. Thank you.
Thank you very much. Well, I'm not going to do any exercises, and I don't have to explain all the design decisions we had to make because Swathi already just presented them to us. Those were exactly the thoughts that are going through our minds when we got the design consumption space offer. But we're going to talk about how design and architecture, from the way we see it, is a very helpful resource in the design and development of these spaces. We have this timeline. I'm not going to go into it, but it's more about to understand that in 2024 is kind of a turning point in this national protocol of drug consumption, and there's new opportunities to implement in some way new ways to talk about harm reduction. So in this context, we were approached by the first one is gone, but by a partner in our university, the CESED. It's a center for to the studies of drug use and policies, and they were talking about starting a new consumption center, and they needed a space to do it. So they talked to us to design it, and we were like, well, interesting. So we went to Sucre in Cali, and this is a bit the context of the neighborhood. It's really impressive for us. We're not into this drug consumption environment since just a year now. So for us, it was really impressive to get into this context and understand really what was happening. So we started to ask questions. The first one was, how do architecture and design help to better implement harm reduction strategies in new supervised consumption spaces? What could offer? The answer is in 3 ways. We decided that we couldn't design a space from scratch, without knowing how the space is going to work. So we started by the service design aspect of it. How do you approach this activity as from the point of view of the caregivers who have to give this service, but also for the experience of the users, of the drug users, and at the end also the community around it and the institutions who are involved. So the service design and prototyping is a way from the design perspective that we can understand and organize these activities. Through the whole process, we had something we call trigger actions. What are trigger actions? There are interventions with the community in the spaces to understand and to develop the acceptance of this kind of spaces in the neighborhood. And at the end, we have the architectural considerations that start with, well, really technical stuff like we have to have some ventilation and lighting and those kinds of stuff, and the structural safety of the building. But it also goes into the design of the space and the decisions of it's colorful or clinical or, well, all the considerations we already heard. And also understanding that there is a lot of furniture needed also for this. I mean, there's always, in these spaces, we have like this plastic chairs and stainless steel desks. But there's opportunities there, which we also discovered are all connected to this cultural context in which we were working, in this case, Cali. So how can service design specifically contribute to building a better interactions and relationships for persons who use drugs and their caregivers in supervised consumption spaces? We did a few things. Service design is based on the design principles of human-centered design. So we're always talking about the people that are involved with whatever is happening. In this case, well, it includes the drug users, but also the caregivers, the neighbors, every institution, organization that is involved. So we have to understand this, and to do this, we have to prototype what is happening and organize the service depending on what is happening. So the co-designing part of it is very important because the ones who know how this works are the caregivers. We are designers and architects. We don't know how this works. The ones who know how to use drugs are the drug users. We don't have that experience. So we have to work and co-design with them to understand exactly what is happening and how we can organize the service. And then we can organize it in the sequence and the experience for each of the actors. And then at the end, this service design we make informs the decisions of the spatial design. So after we know how it works, we can decide how, in which space and how it is supposed to be working. What do trigger actions contribute to the design process of a supervised consumption space? And why are they important in the implementation of harm reduction? Well, the short answer is because it involves everybody. It gets everybody involved in the process, and this is indispensable for the project. In the case of Cali, we had 3 trigger actions. These trigger actions are totally contextual. We cannot say that we have to do these 3 things in other places. If we go somewhere else to design a space, we have to find out what the trigger actions are going to be. The first one in this case was the facade intervention. Did you see there? It was a participatory workshop with the whole team of the center, in which they all started to tell us about what they thought the center means to them and to the drug users. And then they started drawing and making ideas of how this facade would be. We got them all, and we gave them to a professional street artist who transformed this into this image. You don't see it very well, but it's 2 arms holding each other. It's in an embrace, and there's flowers growing from different places. So it's a little bit of hope. It's a little bit about the support this gives and the light that shines on the street. But it all started with the question, do you want the space to be hidden or do you want it to be noticed? And the answer in this case specifically was, we want to be noticed. We want people to know we're here and what we do. The artist was really kind to design something that could be painted by everybody, so it was made with a stencil technique. So we put the stencil and everybody could just paint the little piece of color they were assigned. And at the end, in the door, you see there's a lot of, just a little other color of yellow. We have all the signatures of everybody who participated, that were the caregivers, drug users, passers-by, and us, the architects and designers, and everybody was participating. At the same time, we did something we called the locally sourced furniture. It's also a way to connect with the community. How do we do this? To design something, we don't go to a shop and buy materials, but we go to the neighborhood and look what there is available there. And we found a shopping cart, and we found some reused pallets, wooden pallets, and we were using the same paint of the facade, and we constructed something that was needed by the center at that moment. In this case, it was that they had been going to the neighborhood to give needles and the whole kit to the drug users in a specific place in the neighborhood. And this house, the community center, is on the border of the neighborhood. So they would lose a lot of contact with the community if they retreated into the center. So we made this mobile unit so they can still go out and distribute the kits to the users and promote the use of the center. So this cart was made with help of people in the center, and with a lot of community people who were not aware of what the center was about and what was going to happen there, but participating in this project, they learned about it and starting to talk about it. So it's a way to connect with the community outside of the specific actors. And this can be implemented also for the rest of the furniture. The project hasn't been finished, so we still have to design the space and make the furniture, but this is a method we can use to build the furniture in the center. And the last one was a communal pot. It was a way to close the project at this point, and it was, we made, I think, 200 lunches made by people from the community in the center, and we distributed them to anybody, not only people who use drugs, and not only people we knew, but just anybody who was walking by who was offered some food. And this actually created a lot of context for the center. So the center hasn't been designed yet, but this part is coming. And but these trigger actions were very important in the process of making it known to the people in the neighborhood what was happening. So how can architecture and design create spaces that benefit all stakeholders and transcend a typical health center? That was one of the conclusions we drew, was that it cannot be a traditional health center design. It's not about being perfectly clinical and institutional. It has to be community-based. So it has to be part of what the community wants. So how can the architecture and design help do this? Well, using these methods we've already shown, but also providing, from the context of the project, the understanding of the needs of this specific project in this specific space. So of course there are technical considerations, what I talked about, like telling them, no, you need to have some ventilation because, well, in Cali it's hot and they put on a steel roof, and well, it's not very good environment to be in without ventilation. but also lighting and cleanliness and well, a lot of things important. There are the functional considerations. How does the space work? Where do they come in? Who receives them? Because this is what the service design has taught us in this process, is how does the team approach the persons who use drugs that come into the space? What do they say? What are the possibilities of these interactions? We had some prototypes with real people coming in and using drugs. And we had everything. We had people singing, we had people dancing, we had people fighting, we had telling us stories. In the last picture, sort of a lady that hadn't seen a mirror in a few weeks, and that was part of her experience in this place. So how do we take decisions about how to use the space, where to put the furniture, where to receive people, where to sit and watch what they're doing, to supervise, and what kind of environment do they need and want? You know, so it goes even as far as understanding that music is important, coffee is important, and there are situations in which we cannot do anything else than just make it a very nice place to be. So those are the things we have to implement in the future. Hopefully we have the possibility to do so, but this is what we learned in the process till now. Thank you.
Fantastic, thank you. So now it's time for questions. We've got a half hour left. Do you guys want to throw out some questions? Do you want me to pass the mic around? Who has a question? There's a lot of stimulating conversation here to have. Louis Letellier. Yes, go for it.
Thank you, Liz. Thanks to all. My name is Louis Letellier de Saint-Just. I'm a lawyer from Montreal. I'm the chairman of Cactus Montreal and the chairman of the Quebec Association of Addiction Workers as well. There's one topic that you didn't talk about. It's the relationship with the neighbors, with the neighborhood. So how is it? I have some answers, but we all know, and for folks who are not informed about it, safe injection sites in Canada are going through a very hard time. But what is the relationship? I know that you have only 2 in France. I know that one of your safe injection sites is within an hospital. In Edmonton, you'd have 3 or 4 safe injection sites. In your research, maybe you heard something about that. So I would like to hear, what is the reaction when we do have a safe injection site in a neighborhood? Thank you.
We have one up here too. I'm happy to start. I think it's a great question, and I think keyword the last part what you said is the reaction, right? I think the goal is to not have it be a reaction, but have it be something that people are prepared for. And so for OPCs that have opened in the last few years, especially, I went to the one in Providence a few weeks back, they had consistent conversations with absolutely every person within a certain mile radius around them. They knocked on the doors of every, person living around there. They talked to every stakeholder. Oh, good night. And that I thought was crucial to the relationship with the neighbor. Now, of course, we're seeing for OPCs that have existed for several years, and now that there's maybe changing perceptions towards harm reduction or public substance use, which I think is the real kind of issue that people are identifying as what we call NIMBYs in the United States, like not in my backyard. It's this kind of lack of understanding that these OPCs are not creating public substance use. In fact, they are actually decreasing public substance use. In fact, they're the ones leading to less public syringe disposal and open syringe disposal. And so I think part of that is just the lack of knowledge and understanding. And I think that it's hard for people who operate these OPCs to have these conversations while also operating them. It is busy work. I work on the front lines in Boston, and I don't really want to, at the end of my day, go and talk to all the people who disagree with my work about all the things that they don't understand. So I think kind of having some folks whose dedicated responsibility it is to bridge these community kind of connections and have these conversations with good faith. Because I think we all want, our kids to go to school without stepping on a syringe, which is a common kind of theme that people were worried about in New York City at On Point, because there's a school right across from the OPC, but when the New York Times actually interviewed people at the school, they were like, we're actually thrilled that they're here. They've actually helped a ton. So kind of dispelling some of those myths by having conversation and being very open about what it is we're doing is really helpful.
Yeah, so in our association, Opelia, as we said, we offer supervised consumption in our harm reduction centers. So they are not known as DCR. But I can talk about my experience in Paris when I worked at the DCR. So the first 3 years, the consumptions were there before, many years before the implementation of the DCR. And we remember when it was the COVID, there were restrictions at the DCR, and we had again some street consumption, and the neighbors were getting nervous about that coming back. So it's an interesting experience.
Yes, I think it's very difficult, actually, in France for consumption room, but for center, harm reduction center too, or addiction center. I don't know what keys can we use. I think we have to find a lot of way to speak with citizens about how it's important to be here, how it's important, and it's one of the way to have a quiet city too. But actually, in France, it's awful because our center, I think when we are here for a long time ago, it's okay. Neighbor can say, yes, it's okay. But if we want to change, if we need to open a new center, it's very, very difficult now because all people said, not in my garden. I don't want that in my garden. And actually, we don't know how to do, even if political or government try to, with us, with organization, to be in peace, but it's not really effective now. I don't have the answer at all.
No, just to let you know about the DCR in Geneva, they did a lot of open doors during the first years, and I think they still do it. And they opened in 2001, more than 20 years ago. So we still need to continue.
Yeah, I think as well. It's
in 2011. And everybody was waiting. You were waiting. France was waiting for the decision of the Supreme Court supporting insight. You remember that, Liz? And surprisingly, France opened before anywhere else in Canada. We do have about 40 safe consumption sites, actually, here, and you have only 2. Which is sad.
I guess I would approach this question, thinking about context. The notion of how do neighbors react to, the opening or the introduction of an OPS or an SCS or an SAS. It's not unanimous across geographical spaces. I think, to speak from experience in Canada and Alberta, where there's a decent amount of, I would say, ideological resistance to the idea, to draw on Swathi's idea, this notion of preparing or to prepare, I think about it through more process of engagement. There has to be community buy-in. You have to have partnerships. again, easier said than done. And the idea of having as well, not only the neighbors, but also municipal governments to be supporting and advocating for these, to be also, I think, helping to shift the rhetoric that surrounds the conversation. I can speak to an example where there was a OPS planned to be opened on the south side of the river in Edmonton, and it had been appealed. That plan had been appealed due to its inability to meet heritage facade requirements, among other things, right? And so what it indicated to me was that there was little buy-in, and there was incentive for people to try to find reason to push these types of programs and services out of their space. So, yeah, I don't think there's an easy answer, but
well, trigger actions. No, we can all agree that never 100% is going to agree, and we also understand that it's all context based. In some places it works better. I mean, in Cali, we saw that people were really open to the idea because the neighborhood has been taken over by the drug users on the street. And just saying, no, we have a safe place for them, for a lot of people was positive. But the misinformation and disinformation is part of the problem. When we built the cart, for example, we talked to the guy who sold us the cart and the guy who sold us the wood, and then when we went to buy the screws and to buy a saw, we did that all in the neighborhood. And every time we were doing it, we were explaining why we needed this stuff and what we are going to do about it. And to the guy of the cart, we said, can you bring it to the center, please? Not, I'll take it, but bring it to the center. So you see the center. And when he came, he was looking at the facade we were painting. He was like, oh, interesting what you're doing, and understood much better what was going on when we showed him and talked to him in a very informal way. So I guess the way you contact people and the way you present it is very important. And I think doing actions that are connected to the context can be very helpful.
Yeah, I wanted to just add something. We often hear the same people all the time, but those people who are against the implementation of a DCR, they represent maybe 5%. And we have maybe 30% who are for the implementation and 50% who don't care about it. They're just, okay, let's go and for it. And it's only the same 5% that we always hear and that the media, and we hear in the media.
Yeah, I was just going to piggyback off of what Swathi said. So I'm the executive director of Project Web Renew. We just opened the OBC in Providence. So thank you for what you said, Swathi. That was very correct, that we spent so much time working sort of, building a lot of positive sort of connections in the community. And we really presented ourselves in a way that we provide these really comprehensive services. So we had a community fridge that we had for many years, and hundreds or thousands of people use that community fridge. So people didn't necessarily always associate it with sort of just the overdose prevention work that we're doing. They associated our organization with sort of a larger, more positive, effect in the community. And then I think the other thing that we did do, which we were very lucky, is that it was near a hospital campus. And so we really sort of presented it in this way of, this is integrated medical, this is, is a peer-run and peer-led service, but it is integrated with this hospital. This is a way to connect, folks with services. So I think we were lucky in that we did find a building that was near a hospital campus, but really the relationship building and the individual relationships we created with neighbors in the neighborhood, I think that was the key, and that took many, many years, and we're still working on it. So thank you, Swathi.
Hello, my name is Alex Stevens. I come from the United Kingdom, where we have now one officially sanctioned overdose prevention centre for a population of about 70 million people, thanks to our brilliant colleagues in the great city of Glasgow. There are lots of people we've been working with in different cities around the UK who would like to open an OPC even without official sanction. And the main thing that stops them is the fear that the police will immediately shut it down. So I want to ask our French colleagues, did you warn the police? Did you negotiate with the police? Did you tell the police? Are they trying to shut you down in your unsanctioned services?
No, we have relationship with police before. We tried we tried ESAR project as a usual service. We know that there is no protection for drug users by the law now because we are not a consumption room. So for worker, it's okay because we are in our mission. But for users, drug users, no, it's not okay. We know that. Normally, with our centers, Service of Police says it's okay if they come and we don't arrest just close to our centers. So we just say nothing for the moment and hope it will be okay.
Yes, I'm a field worker, and I sometimes meet the police, and some police, even a few years ago, thought that there were already this kind of services in our centers. I go to some meetings, and when they say and they see that people take drugs in the street, they say, why don't they go to your center to do it? But they are also field workers and not the politicians.
Hi, great presentations, great discussion, everyone. Dan Ciccarone, San Francisco, US. I have a question for the architect. So we know that lighting is super important in these spaces, you know, for people finding veins and having accurate access to their veins. So can you give us a little more technical insights in terms of lighting design? I'm really curious.
Well, we haven't taken any decisions yet, to be honest, but we understand the difficulties. Of course, there's lighting that is going to make finding a vein very difficult, but there's not many kinds of lights. There's a lot of lights that make it possible. And it's a lot. We were thinking a lot on the lines of a spatial lighting that will be more cozy and nice. And then there's specific lighting that maybe even can be manipulated by the users, because there's sometimes if they want to inject, we heard some of them inject themselves in the neck. Well, the lighting will never be perfect. Unless we give them something they can manipulate themselves. But those are all answers we have still to define. And it also has to do a lot with budget and possibilities in the space, because we have to work within a space that's already built. So we have to understand how it works. And we still have to understand with the prototypes we've been doing and the center has been doing, how many users, how many spaces are needed exactly, how many people at the same time are using the space. There's a lot of variables that make it possible or not to implement some of our decisions. But I think we were thinking more of creating a more cozy space with indirect lighting and more yellow lighting, and having some possibilities of direct lighting for the users in their consumption space.
I have a funny lighting story from Insight, just because when we opened, we wanted there to be really good like target lighting down on the booths, as well as obviously dimmer lighting, so it didn't feel like you were in a stark environment. And so our architect designed very nice lights, but they were very expensive. And in the end, the health authority said no. They're too expensive. And so he paid personally out of his own pocket, privately, 45,000 Canadian dollars to put those lights in Insight. Nobody ever gave him the credit for it, and I always love being able to tell that story because it really just came down to one guy saying, yeah, I believe in this enough to spend the money. Similarly, our lounge chairs in the chill lounge, where it was meant to be people could, after they've used, just relax, and meant to be a nice environment, nice inviting environment. We had this whole idea about food and drinks and it being nice and relaxing and, you know, nice big cozy chairs. And we were told, no, it couldn't be too inviting and have food and coffee because that would draw people into the center to use drugs. And B, the too comfy chairs would mean they stayed for too long. So we had to have these horrible hard seats. They removed all these really nice comfortable chairs that we actually got and put in like very hard upright chairs so that people wouldn't stay, like super dumb. Like, so some of these choices are not optimal. They're just purely regulatory and or political in terms of the ability to get things done. I commiserate with you. Anyway, any more questions? Oh, Katie.
Hi, my name is Katie. I'm from the United States. A lot of the questions focus on the folks that are going to be using these centers, but I wonder if you guys have any thoughts on the folks that will be operating the centers and the services and the that might be provided for them. It'll be a lot of work and a lot of stress, I imagine. They're probably seeing a lot of things that maybe maybe triggering, especially if peer workers are in those environments. A lot of vicarious trauma potentially. So I just wonder if folks have ideas on how we might be able to provide services for the folks working in those centers as well.
I think that's a great question and something that I've been thinking a lot about. And the next iteration of this project, which will be surveying like different OPCs across the globe, will include a lot of questions about that. Some of the coolest things I saw are centers that actually kind of leveled the playing field here. Like, you know, there's a interesting discourse I think happening right now in this field about peer, and there was I think great talk happening simultaneously to this one about that. And you know, is peer just like a not funded staff person with lived experience? You know, I don't know. And I think we all need to talk about this. But what I think is cool is like some of the centers that actually like, don't really make a strong distinction between like, you know, people who are staff and people who use the services. Like anybody can be anybody. To the point that I think like, you know, On Point offers what's called the needle-based acupuncture, thank you. Acupuncture and acupressure. And that is like folks who work at the center can use that. Folks who come into services can use that. Anyone can use those services. I think that's excellent. I think increasingly we're seeing OPCs with staff wellness rooms. I think, you know, Providence, you can shout out there again, which is really exciting and a place for people to sort of decompress a bit. But those like services don't always have to be separate. Sometimes it's helpful too, but sometimes it's, you know, stigmatizing too. And to create these big barriers. At the same time, obviously, we're trying to protect everybody's peace in these places. So having wellness services that folks can access, whether that's a person that is using the service and not a staff person or is a staff person can also use the services. Like, I think that's been some of the coolest stuff. And I think right now we're actually entering, I think, an era of considering this more often. And there are some physical spaces that speak to that. There are outdoor spaces that speak to that. But there are also individual services within these spaces that speak to that.
Yeah, so to talk about the ESAR project, it's part of our normal services. So it's just one service apart from all among the others. We do drug checking, we do blood screening. I gave needles and all harm reduction products for many years before I supervised. So that's already part of our job as nurses or social workers. But when we accept consumption in our rooms, we had some more training, first aids, overdose management, and safe injection, which is a bonus.
Yeah, I think this is a great question as well, and one that, you know, as a nurse and having worked in this space for a number of years as well, that it makes me think a lot about, you know, when often working with clients or community members or patients, you know, this idea of like, what is keeping you well often comes to mind for me. It's area that we'll explore. But when we turn it back on ourselves as service providers, as people who are facilitating these kinds of services and programs, it's somehow paradoxically counterintuitive. We don't know how to always respond. I think, as has been mentioned so far, being able to provide more comprehensive education for service providers is helpful, as well as some of these wellness strategies that Swathi was talking about. But I also think about, trying to find ways to establish more comprehensive benefit packages for employees, as well working with their schedules in more flexible ways that are accommodating and supporting in that respect. Also, though, I think something that comes to mind is just how camaraderie has such an effect to support wellness of people who are providing these kinds of supports. And in many respects, we as social creatures do our own job of building the community around us to support ourselves when we deal with hard things. And so I think just ensuring that the environments and the spaces are conducive to those kinds of mechanisms or strategies will help to create, I would want to say, sustainable, support in many respects. And I think that's part of the challenge, is finding a way to sustain a healthy and long-term support.
We didn't have much more time to do it, but the whole service design process we made was in first case based on what the care workers and service providers were needing. Because of course the service is to get a safe place for the drug users, but of people who use drugs, but the ones who have to do it every day and have to understand how it works and what choices they can make while they're doing it are the service providers. So they were the principal actors in our service design process. And in our experience, for the team we were working with, they were working knowing that probably the funding was going to end. They knew that the program probably wasn't go on, and most of them were going to lose their jobs. And still, they were there the whole time we were doing the prototypes and the trigger actions and everything. And especially in the trigger actions, they really found motivation acting, because people who do this because they love to do it and they want to do it. So I think it's also about creating an environment for them to feel helpful and respected, and this can happen with the whole process.
Okay, well, thanks so much. That was a really awesome and enlightening panel. And I just want to add one thing about Cali. When I came here 2 years ago, when they were first talking about the site at Sucre, and I had the privilege of meeting with the staff, and they had like a sort of an amazing team day where there was 50 people in the room all sharing different aspects of why the work mattered to them. I learned a really interesting thing that had happened in that community, and that was they had embarked on a really interesting mapping exercise, at the heart of which were listening sessions to map out the community. And I think we think of community as separate things, right? There's the community of drug users, there's the community of businesses, there's the healthcare business sort of intersection with the community. And what they did in Cali, which I found so incredibly amazing, is they actually created these dots mapping of the community and the various communities and the various relationships. And then they held these social events like parties, non-stigmatizing events, nothing oriented to drug use, just involving people who use drugs and hosting these events like fashion shows or whatever. We did a lot of this in Vancouver too, in the center of the area that was the most contested part of the community, where people were seen as either part of that drug user community or part of that business community. And these sorts of events and these community sort of crossover things where you're integrating people into the fabric of normal life and destigmatizing the humanity of the people that we're trying to reach through these centers, I think is one of the most remarkable ways to change that conversation. And I see that in Cali, and what they showed through their dot mapping was that after they had initiated these events, the number of connections that were made between an individual and all sorts of other members or stakeholders of the community, whether it's business or healthcare or police or whatever, had expanded exponentially. So now the drug user on the corner knows the guy who serves the hot dogs, who runs the motorcycle shop, who whatever. And this social integration of people who use drugs into communities, I think, is a really key piece that we're missing in a lot of our societies, because we alienate people who use drugs because we don't see their humanity. And for me, these spaces have the opportunity to shift that, whether it's harm reduction centers that more generally are serving people through a wider service and integrating injection use or use into the centers, or just changing how we even conceptualize what these supervised spaces need to look like. Anyway, that's my 2 cents. This was really great. Thank you all for the work you're doing, and thanks for being here.